about cancer, we often think of organs like the breast, lungs, or colon, but very few people realize that cancer can also develop in and around the eye, affecting vision, appearance, and in some cases, life itself. From eyelid cancers, they may look like harmless bumps, to rare but serious cancers inside the eye, early signs are often subtle and often missed. I'm Puvanraj Kanagraj, and I'm the Associate Editor of Cancer Matters, and this is Inside Oncology. Today, we are joined by Dr. Nazila, Consultant Ophthalmologist and Oculoplastic Surgeon from Sunway Medical Centre Velocity, to shed light on the different types of cancer, eye cancer and eyelid cancers, how they're present, how they're diagnosed, and why early detection can make a critical difference. This conversation is especially important for patients, caregivers, and even healthcare professionals, because when it comes to eye cancer, what you don't see can hurt you. Welcome to the show, Dr. Nazila.
Thank you.
So I'm going to kick off a question. This is a very, to me, it's a very rare type of cancers, and we often talk about cancers, on a monthly basis. There are special months dedicated to very common cancers as well. Many people may not realize cancers can develop in or around the eye. Can you explain what are the different types that are available, that are present? What types of cancer do you see often in Malaysia as well?
Right. Thanks for the question. When you talk about eye cancer, if by definition it's cancer originating from the eye itself, but you must also think that when you have eye cancer, it can also broadly means cancers originating from the eyeball or structures surrounding the eye. It can be primary, that means the cancer cells originate from the eye itself or the surrounding structures, or secondary eye cancer, that means the primary or the origin comes from other parts of the body. So what are the, not to say eye cancer is not very common, but primary eye cancer, which you commonly see, is like those malignant melanoma, of the uveal tract. For example, that comes from the choroid, ciliary body. That is the black part of the eye, and also iris. And it can also originate from the retina, like retinoblastoma, which is a well-known eye cancer of childhood. It can also arise from the ocular adnexa, like the conjunctiva melanoma, and also intraocular lymphoma. You can also have cancers originating from the orbit, from structures like lacrimal gland, carcinomas of the lacrimal glands, lymphoma, orbital lymphoma, and things like that. Also rhabdomyosarcoma. It's also another type of orbital malignancy in childhood. Mainly seen in a child around 5 to 20 years of age.
And you mentioned secondary eye cancer. Could it be possible that if a patient is having cancer in other parts of his or her body, could it spread to the eye and then lead to eye cancer as well?
When you have these secondary cancers, it's actually a metastasis from other parts of the body. For example, like the breast, lungs, or also prostate. When it goes to the eye, it manifests as if another cancer, right? But it's secondary because the main primary cells come from the original parts like breast or lungs. But the manifestations, may be difficult to differentiate whether it's primary or secondary. Only through history and also clinical findings, we can actually differentiate between these two.
So let's say, in terms of early signs and symptoms, could you run us through what the signs and symptoms could look like? Do they differentiate from, let's say, if it's a pediatric case to maybe an adult who's having eyelid cancer or eye cancer? What are the symptoms and signs that people you should usually look out for?
Right. Let's talk about pediatric cancer like retinoblastoma. So it affects younger children. Sometimes you can have it at birth, and up to probably 5 years of age. So babies and small kids, they normally don't complain. So it's very important for the parents or the primary eye care doctors, to actually pay attention, right, to any subtle signs, that these children may manifest. Okay, so one of the most important thing to look for is white pupillary reflex. That means when you shine torch to the child's eye, you'll see some white reflex, which is not normal. Like the cat's eye.
Yep.
Cat's eye reflex. Okay, that's one. Number two, they may be misalignment. Okay, or screen, misalignment of the eye or screen.
So when you say misalignment, doctor, what does it? How does that physically show?
That means the eye is not straight.
I see.
The eyes, both eyes are not straight. Yeah, one eye may be looking inside or outside, outward. Yeah, so that's number two. Number three, child may not be healthy overall. Yeah, there may be protrusion of the eyeball. Yeah, so these are the signs to look for. Yeah, to be aware of. Okay, as for the adults, they may be complaining of symptoms like blurred vision. Okay, floaters, flashes of light, dark spots or curtains, in their vision. Yeah, there may be protrusion of the eyeball, double vision, and redness. Yeah, pain may not be there at the initial part. Yeah, if there's pain, it could be at the late stages or.
So how do you typically diagnose these symptoms or signs? Of course, parents, they may have suspicions. And when they come into you, is there a test that you would conduct? Usually a lot of cancers, they have these early screening tests, right? Is there something similar for eye cancer as well?
Yeah. For eye cancers, right, it's always the same thing, the flow that we go through. Okay, history taking is very important. And most of the time, diagnosis can be made clinically, all right? But of course, imaging, helps in establishing the diagnosis. Okay, for example, in eye examination, we do dilated fundus examination. Okay, so this dilated fundus examination may reveal a lot. Okay, for retinoblastoma, you can see lesions on the retina itself. Yeah. Ceilings, vitreous ceilings, and also if it's large enough, you could actually see the lesion, at the back of the eye, right? And other modalities, which you can do in clinic, like the ultrasonography, B scan, A scan, B scan, and with the advent of technology nowadays, we can also do 3D retinal imaging in the clinic itself, or in the operating theatre. Okay, and we also subject patients for, especially for staging and all that, for MRI, magnetic resonance imaging. As for the adults, the same thing, dilated retinal examination is also very important, to get the right diagnosis.
You mentioned that this particular cancer, it's rare. You don't see it too often. But due to this, the status of it being quite rare, would you say that patients come in too late because they may feel, it's just, I'm getting old, so I may have blurred vision? Are they, is there an increasing instance where patients coming too late? What's usually the case with patients in?
Okay, and patients may come in late because they may mistaken this blurred vision and all that due to cataracts. Okay, something more benign. Okay, and like floaters and probably flashes of light. With increasing age, they may have this kind of symptoms. So these symptoms sort of delay, or masquerade the real situation. The other thing is that what do you call this? When you have, tumors or lesions that are growing very slowly, but and small, so they may disregard it as, just something benign and, not to worry, things like that. Sometimes diagnosis can be delayed as far as 6 months to 1 year, making the diagnosis the prognosis, poorer if they come in late.
So when you mentioned, in those instances where they come in late, is it at the stage 3 or stage 4, or how would you classify them?
Okay, when they come in late, because different kind of cancers, they have different types of staging and all that, okay? So when we talk about late, that means it may have metastasized, okay? That's one. It may have spread. It may not be localized anymore. It may have, multiple lesions in the eye, because our aim is to actually save the vision, number one. Number two, if we can't save the vision, we want to save the globe, the eyeball, And if you can't save the eyeball, you want to save the lives, right? So most of the time, if patient comes in late, then our only hope is to save the life, all right? May not be vision in the first place. Eyeball maybe, but vision may just go blind, because of the delay in the diagnosis.
Doctor, you did mention there were a variety of eye cancer, types of cancer, right? And which of these types of cancer, particularly these categories, could lead to a very severe stage where you would have to remove the globe, the eyeball out of the patient, or even it could really threaten your life?
Okay. In pediatric age group, that would be the retinoblastoma. Okay, sometimes it can affect just one eye or even two eyes, depending, because sometimes it's hereditary, retinoblastoma. Sometimes it's sporadic. Okay, it just happened. All right, and depending on the size of the tumor, okay, and if it affects the optic nerve, if it has already affected the optic nerve, the globe has to go. All right, so basically large tumors and affecting the optic nerve, the globe has to go.
I see.
All right, and as for the adults, when you have uveal melanoma, like the choroidal melanoma, ciliary body melanoma, which comprises about probably around 85% of all the malignant melanomas of the eye. If it's large enough, and it affects the optic nerve, again, the globe has to go.
I see. You mentioned that in some cases it could be hereditary. So, family history is a very vital factor, especially in cancer. What role does knowing your family cancer play in this case, for example? Does it play a huge influence in terms of, if your parents or your grandfather or grandmother may have eye cancer, does that increase your chances high? Or even, doctor, we were doing this article on prostate cancer, and they were saying that when you have if you have a history of breast cancer in your family, your chance of prostate cancer is high too. In this case, is it similar, or what's that like in terms of family history?
It's something similar, We have this, in retinoblastoma, for example, we have this RB1 gene mutation in the family tree, So you can have that inherited, As for malignant melanoma, family history may be positive, may be negative, because it mainly affects the adults, the aging adults, fair skin, right, exposed to sun, a history of smoking and all that,
I see. So we obviously go under the sun quite often.
Sure.
Would you say that, what would you encourage people, or even potentially patients or non-patients today? Of course, for skin, you have your sunscreen, and then you've got some people say get your UV protected umbrellas. But in terms of sunglasses and eye protection, is there a very specific eye protection that you would recommend, or what's that like usually?
Okay. If you go out in the sun, it's very advisable to use sunglasses or sunscreen that can protect UVA and UVB, ultraviolet A and ultraviolet B, which can block off no more than 90%. So that's one. You can also wear a hat, big one, if you're exposed to sunlight. If you're under the sun most of the time, okay, and also avoid smoking.
Now let's talk about treatment. Obviously, there's different categories of eye cancer. There's also different stages of eye cancer as well. Focusing on pediatric first, what are the sort of stages of treatment available, and what kind of technology that comes into play as well? And in your experience, have you seen an advancement of technology that now makes it a lot easier to treat cancer, eye cancer, and also increase chance of survival?
Yeah. If you talk about retinoblastoma, the pediatric eye cancer, depending on the size of the tumor, it's very important. Okay, if it's small, small to medium, of course, newer modalities, like what do you call this, radiation therapy, plug brachytherapy or external beam radiotherapy can be advocated. There can also be adjunct treatment like laser treatment, or transpapillary thermotherapy. Okay, but if it's large enough, enucleation or the removal of the eyeball needs to be done. Okay, another thing with all this, patient needs to be what do you call this, advocated with chemotherapy. Okay, so multidisciplinary approach. It's the ophthalmologist, pediatric ophthalmologist, oncologists, pediatric oncologists, and also the radiologists need to come in, together to manage this patient. As for the pediatric oncologists, they have this, regime for this kind of pediatric cancer. It can be delivered systemically, systemic chemotherapy. It can also be intra-arterial chemotherapy. And for the eye, there may be administration of intravitreal. That means inject chemotherapy into the vitreous.
I see.
To control the tumor.
And would you say this is similar to the adults?
Similar to the treatment of malignant melanoma.
I see.
Yeah, if it's small or small to medium, there may be some less invasive kind of surgery. Enucleation is spared, for the larger tumors. Okay, if it's very small, you can actually practice observation, especially if it's slow growing, like if it affects the iris, otherwise, you can do laser therapy like photodynamic therapy, what do you call this, papillary thermo treatment, thermotherapy. You can also do radiation therapy, the plug brachytherapy or external beam radiotherapy, apart from chemotherapy.
I see. So, doctor, when patients have, these signs and symptoms, the first person they would see, the first line of sort of prevention or cure treatment they'll see is the GPs, right? What is your advice to GPs in terms of spotting the signs and symptoms rather than dismissing it as just, oh, you're just allergic to something, or it could just be a rash that could trigger? Because, like you mentioned, these could be lumps or even blurred vision, which could be very much mistaken by age or, other common factors that could but what would you advise to GPs to better identify these signs?
So you're talking about patients with no known history. Okay, right. So if these patients come to GP, they should be alert of some symptoms that are being complained, like sudden loss of vision. Okay, when there is increase in new floaters, flashes of light. Like dark curtains or spots in the vision, double vision, okay, and also a protrusion of the eyeball. When examining them, they should be alert of, certain things like, for example, what they can see grossly from outside, because GP doesn't have this, sophisticated, what do you call this, as a machine to examine like ophthalmologists, okay? So what they can at least do is to shine their torch, look for any abnormality, and what do you call this? If it's the lesion is coming from the eyelid, look for signs like loss of eyelashes, okay? Any ulcerating lesion, okay? If it bleeds with just upon touching, all right? And if there is loss of congruity of the lid, these are signs that should prompt them to refer these patients immediately. Okay.
Another common question that people might have is, Malaysia, the rate of NCDs are very high. So diabetes is, one that sort of plagues Malaysians a lot. When it comes to surgery, patients would often ask, I've got diabetes, so does that mean my rate of survivorship or rate of successful treatment goes down because if it becomes invasive? How do you treat patients like this, doctor? Patients with diabetes but may require invasive treatment?
You're saying that patient is diabetic and having eye cancer as well?
Yeah.
Oh, okay, right. I wouldn't say that, of course, being diabetics itself is in what you call an immunocompromised state, a condition, yeah? So if the diabetes is, well controlled, yeah, that shouldn't actually reduce the what do you call this, the successful rate of treating these cancers. There are a lot of patients out there, who are having diabetes and at the same time having, cancers. Yeah. So I think if their control is good, yeah, that shouldn't interfere with the prognosis and that. Yeah.
Now, as we come towards the end of our conversation, right? What gives you hope over the future of eye cancer treatment and survivorship? It's still a very rare cancer, but nevertheless, it's still a cancer, right? And when it comes to treatment, you see advances every day. But how do you feel about the future of eye cancer treatment? Do you think things are moving at a pace where you can treat easily? Are people becoming more aware, or should we need more awareness as well?
I think the most important thing in treating cancer is first to create awareness among the public. Okay, let them know that such things exist. Okay, and with the advent of new imaging modalities, like one of them is the 3D retinal imaging, MRI, series scan, PET scan, and all that. Yeah. And also with newer treatment modalities, apart from chemotherapy, surgery, radiation therapy, and all that, we have immunotherapy. Okay, so I think prognosis should be better in the future, yeah, with all these combined together.
I see. Thank you, Dr. Nazila. Eye cancers may be rare, but as we have heard today, their impact can be profound, especially when diagnosis comes too late. What stands out from this conversation is that many warning signs are hiding in plain sight. Has persistent eyelid lumps, unexplained vision changes, or eye symptoms in patients with known cancers elsewhere in the body. Early referral, timely imaging, and multidisciplinary care are changing outcomes and offering patients not just survival, but the chance to preserve the vision and quality of life. A big thank you to Dr. Nazila from Sunway Medical Centre Velocity for sharing her expertise and helping us better understand a topic that deserves far more awareness. If you or someone you know has persistent eye or eyelid symptoms, don't ignore them and don't self-diagnose. Get your eyes checked. It could save your sight or your life. And this is Cancer Matters.